بسم الله والحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. The title of this lecture is Restoration of Facial Defects, given by Dr. Walid Sadig. Rehabilitation of facial defects is a complex task requiring an individualized design of the technique for each patient. Acceptance of facial replacements has improved dramatically since the introduction of dental implants. Facial defects can result from neoplasms, trauma, congenital malformations, and burns. Facial neoplasms are mainly basal cell carcinoma, squamous carcinoma, and malignant melanoma. Basal cell carcinomas is considered benign if it is excised early, but if it's left untreated, it can be very aggressive and killer. Late management of basal cell carcinoma may necessitate large resections with devastating aesthetic results. Squamous cell carcinoma of the skin is a common form of skin cancer. Despite its malignancy, it is not life-threatening, but locally it can be destructive and may metastasize to lymph nodes, which requires aggressive resection. Benign proliferation of melanocyte is termed nevi, and the malignant proliferation is called melanoma. Melanomas are highly malignant and require extremely wide resection. The most common facial replacements are nasal, auricular, orbital, ocular, midfacial, and cranial implants. In a maxillofacial clinic, some miscellaneous prosthetic parts can be fabricated, such as facial masks for burn patients, and other somatic parts like fingers and foot, and breast, nipples, areola for post-mastectomy patients. Considerations before any facial replacement: there should be a real indication, predictability of the aesthetic outcome, lifelong commitment by the dentist and the patient, material availability, laboratory support, and dedication by the dental technician and the prosthodontist. Materials used for facial prostheses include acrylics, polyurethanes, and silicones. Currently, silicones are the most commonly widely used material to fabricate facial replacement because of its biocompatibility, texture and softness, adaptability to coloration, and easily processed. The main disadvantages of silicone elastomers are tearing of edges, short durability, and the extrinsic colorations tend to wear off. Methods of retaining facial replacements include skin adhesives. The ProsAid medical grade adhesive is an example of commercially available product. The other form of retention is to engage the defect undercut in addition to the skin adhesives. And the last but not least is the use of osseointegrated implants at the maxillofacial region. What is cranial implants? Cranial implants or reconstructions is required to restore skull contour and protect intercranial structures by biocompatible materials. These defects in the cranium can be results from neurological disease, injuries, and motor vehicle trauma. This case is an example of cranium defect resulted from road accident. Impression of the defect was registered and wax model was created to restore the skull contour before changing the wax into heat-cured acrylic. This is another case of cranium defect showing the steps of fabricating the cranial implant from the start to the end. This case shows a cranium defect resulted from cancer resection. The two lower slides show the contour of the defect and the method of taking the impression with alginate and plaster. In this slide, you can see the size of the custom-made flask and the wax model before wax elimination. The cranium implant was perforated to allow fiber integration of the scalp soft tissues into the acrylic to enhance the stability. Currently, with technological advancements, cranial implants are customized by utilizing computerized tomography and 3D printing, using a variety of material like PEEK, which allow intraoperative adjustment and superior biocompatibility. Now we will move to nasal defects. Tumor ablation by the head and neck surgeon or the plastic surgeon called rhinoplasty. Unlike the surgical reconstruction, prosthetic nose repair is very simple and fast. With rhinoplasty, it is recommended to resect the nasal bone and avoid distortion of the contour and position of the lip, cheek, and nasal labial folds. This is to increase the success of the nose prosthesis. To fabricate nasal prosthesis, facial moulage must be made. The moulage can be limited to the nose area or full face impression. Full face moulage starts by lubricating the face with petroleum jelly. Soupy mix of alginate poured over, then gauze is embedded within the alginate. Plaster mixture with the slurry water applied over the gauze. The master cast is produced by boxing the imprint with wax, then poured with dental stone. If implants were installed after the resection, acrylic substructure is fabricated over the implants to incorporate the magnetic attachments. Nasal sculpturing is completed over the acrylic substructure. During the nose trial appointment, the appropriate type of silicone is selected and the intrinsic color matching is started. Color matching for facial prosthesis is trial and error process of adding pigments in small quantities to the silicone base and frequently compared to the patient's skin. Flock is added to add texture and simulate blood vessels, and transparent plastic sheet is used for comparison with the patient's skin. After molding and pouring the silicone, extrinsic coloration and glazing will be performed. Cases with poor prognosis of the prosthetic nose happen when the surgeon elected to do partial rhinectomy, and the mobility of the soft tissues surrounding the defect is severe. In this slide, you can see the resected nose with immediate implant placement and post-operative picture after the healing phase. Fabrication of an implant-retained nasal prosthesis starts with an impression for the implants with the defect together. At the try-on appointment, we have to verify the margin placement, contours, and surface textures of the wax pattern. At the silicone try-on appointment, extrinsic coloration applied slowly and carefully. This slide shows an example of a partial nasal prosthesis. The retention of the prosthesis is compromised because of the functional movement of the cheek during eating and talking. This combined nasal lip prosthesis masks the nasal defect extending onto the upper lip. A mustache was placed into the silicone to camouflage the artificial appearance of the silicone. Use of craniofacial implants to restore nasal defects is becoming very popular. The osteotomy site, 2 implants in the nasal floor and 1 implant in the glabella. Implants for extraoral sites are designed for delicate facial bones. These ultra-short length implants are standardized by 3 to 4 mm. It comes with a flanged collar portion with 5 to 6 mm in diameter. This is to prevent deep placement in critical region. The majority of manufacturers make both bone level and tissue level implants. It is worth to mention that implants should not exit through the mobile tissues of the lip. Also, these implants should not be positioned too far posteriorly, making hygiene difficult. Furthermore, implants placed in the glabella have shown a low success rate. It is highly recommended that the metal framework construction are designed with horizontal and vertical bar joint attachment to maximize the retention and stability of the prosthesis. Silicone should not be attached to the metal bar directly. An intermediate acrylic resin substructure must be fabricated to incorporate the nylon clip within the gold housing picked up inside the acrylic substructure.